Hello, everybody. Welcome to our follow-up on population health management and what's next. I have got our two guests from last week joining us today. We have Dr. Scott Cherry, Axiom's Chief Medical Officer, and we have Dr. Pete Matos, the CEO and founder of Tracos Health, LLC. We had a really great conversation last week about the role of public health and how we are managing in the middle of a pandemic, and how public health and the view on the education that both Dr. Cherry and Dr. Matos have in this realm has helped us determine what we do with a pandemic and how we can support clients and the public throughout this process. So we have some additional follow-up questions from last week that we didn't get to. So we're going to start there. Thank you both, Dr. Cherry and Dr. Matos, for joining us today. If you want to say hi to the group.
Hi, everyone. Thanks for tuning in to our weekly webinar. It's been a pleasure to kind of present our ideas and the facts that have been unfolding with COVID. And as the science learns more, we continue to iterate on our programs and information. So again, thanks for your time today.
Thank you, Dr. Cherry. Dr. Matos.
Hi, everyone. Second what Dr. Cherry said, and nice to have you all back.
Yeah, we've got a couple of us remotely today. So you've got me up in the mountains, and you've got Dr. Matos hiding somewhere in the center of the U.S., right, Dr. Matos?
Yeah, I'm in the Black Hills of South Dakota.
So we've got minus the camera and Dr. Matos today, but I'm sure we'll be able to get some great questions answered. So our first follow-up question that we've got came from Michelle. Michelle said, in terms of data, with the directive to stop providing numbers to the CDC, where do we turn to get good data? How is this going to affect our ability to know what is real? Dr. Matos, you want to take that one first?
Yeah, sure. So I think there's other ways that we can get data. So there's other reports that are still reported to states. So it just slows down the reporting, but it's not going to stop the reporting. So there's sites like the COVID Burden Index. I can't remember the other site. I think it's COVID-19burden.net. There's another one like that. So there's ways to look at those things. And then also diagnosis codes, what are called ICD-10 codes. We can also look at those from CMS data that is released not necessarily in real time, but every few weeks. But there are people that get that data in real time, and we're still able to see what actually is going on. And that data is probably more predictive than what you see on the Johns Hopkins website and also the WHO website that kind of are just counts. Because if you think about it, when someone shows up for to get tested and they're positive, they've probably been positive for a number of days. And the other thing, if you test positive, deaths are going to lag 3 to 4 weeks probably behind those positive cases. So they're kind of really lagging indicators, whereas more of a leading indicator is diagnosis codes. That's what I track, and that data isn't necessarily readily available to the public. So the people that need to know what's going on, they'll still know what's going on.
That's a great point. Dr. Cherry, any follow-up points to that?
Maybe just another angle. I definitely echo what Dr. Matos was saying. One thing I would just maybe speak to is how we really need to exercise discipline on the information we digest. If you are receiving an article or a video or a publication that has a narrative to it, you really want to be careful. You want to utilize data that actually is facts and not narration necessarily. I would say for a lot of our clients and our audience who are in occupational health and safety, utilizing a medical expert that can help decipher which information you should focus on is key, and really trying to just focus on facts. I know myself and Dr. Matos will look a lot at studies from institutions of higher learning that focus on epidemiology, biostatistics, and public health. And so I know the news has been shouldering a lot of the burden in sharing information, but it usually comes with some type of narrative, which may kind conflate many facts into one kind of sincere story potentially, but in my opinion, it can be misleading. So exercising, again, discipline on how you are looking at information is key.
Yeah, I know that one of the themes we've had in a lot of our webinars recently, Dr. Cherry, that you've spoken to is exactly that, making sure if you're looking at the news and social media and all of this information that's coming out, that you do exercise that discipline to make sure that the data and the information you're looking at is from valid sources and is something that, that we can actually verify, and that it helps weed through a lot of the misinformation and maybe disinformation out there in the world today. So thank you. Those are great suggestions. Our next question came in from Fernando. And this has been a big topic this week. A lot of schools are set to start reopening very, very soon. Where we are in the Axiom corporate office is in Texas, and schools are set to open in the next couple of weeks. So Fernando wants to know, what do you think about schools opening for classes? Some school districts are offering online learning, but not all. And in addition, Dr. Cherry, I'd like you to start. There's been some additional information coming out about other countries and how they've addressed the reopening of schools in the recent days. So Dr. Cherry, will you take that first, please?
Sure. I think the best way to move forward is through an evidence-based medicine approach, to where we make suggestions to the organizations that we support. The best would be through evidence-based medicine, so we have a firm understanding of why we're making different recommendations regarding prevention or treatment, things like that. There has been a lot of concern of COVID across the general population against worker categories, and then now I think with schools as well. A lot of data has been showing that COVID really is affecting certain vulnerable populations compared to others. And so although, many may get infected, only a small proportion, maybe less than 5%, would need hospitalization. And then well under 1% may succumb to this infection. And so when we're talking about schools, we're looking at age categories and looking at if those age categories are at higher risk. So right now, one of the vulnerable populations is an age group of 65 and older that the CDC has identified. The correlate to that is that younger people are actually doing quite well in the aggregate. So, the children, teenagers in general are not nearly as affected as those in the older age groups. Of course, chronic medical conditions may change that risk profile, but in general, when you're younger, you usually have a less risk of chronic medical conditions as well. So a lot of the data that I've seen has showed a consistent trend that young people are usually doing better. And so you need to balance that risk of reopening the schools with, one, are the students going to be a risk to themselves, to the teachers, and to the community? And so right now the data, I think, supports having schools reopen. And this should be done methodically, though, where there's active surveillance of both student and teacher and staff health, looking for symptoms, using an active surveillance approach. We might have talked about active versus passive surveillances in our webinar last week, but active surveillance is where you're actually spending resources and energy and actively looking for diseases of interest, where passive may be, oh, if I go to the doctor next year and I get diagnosed, then that's when it'll become apparent. So those are kind of my general thoughts about schools reopening. And I do appreciate what you said, Dara, about some of the a recent study about schools in the international communities that have reopened without much issues at all. So How about you, Dr. Matos? What's your look on this?
Yeah, I think that's, I think everything you said I agree with. And I think each person needs to do their own self-assessment. And maybe, how about, I always like real world, vignettes or stories, right? So we have a friend, my son's former baseball coach. He babysits his grandson who's 6. Grandson gets COVID. His granddad ends up getting COVID and ends up, in the hospital, at the VA hospital locally. And I think that story kind of just gives a word of caution. Kids are carriers, and I think the risk is to family members that are in their household that are older, that are in that high risk group defined by the CDC. But then also the risk is to the teachers. And, you think about it, Dr. Cherry talked about active surveillance. We're actively surveilling sports teams. We're actively surveilling movie stars in Hollywood, but we're asking teachers just to wear a mask and to go to school without that active surveillance. So I think there's got to be a way to mitigate risk, decrease class size, utilize social distancing, utilize masks. These are all the tools we have in our tool chest to mitigate the COVID risk. And I think one of the things is the power of masks. There were 2 hairdressers in Missouri that ended up, cutting the hair of 119 of their clients while they had very mild COVID disease. The good news is not a single one of their 119 clients that they cut their hair got sick. Why? Because they both wore masks. So I think we actually have more tools than we think, and we have more ways to protect ourselves than perhaps what people would like us to think. And I think that it's just really important for all school districts to just be transparent as to what their plan is. And I think to be flexible. And at least what I'm seeing is around the country, and at least with some of my family and relatives, I've kind of seen 3 options. One, 50% capacity. The other is you go on a rotating schedule. And then the third is online schooling 100%. And then the fourth really is, back to normal. But I think that's pretty rare, because I think depending on what the situation on the ground is with COVID, I think everyone needs to just look at their personal risk, look at the risk of their family and those in their household, and decide what works for your family. There is no right or wrong answer. It's finding what works for your family and what your risk tolerance is and what you're comfortable with.
Yeah, those are great points. I'm sorry, Scott, were you going to say something?
I love the contrast, Pete, about, how different industries are approaching it through an active surveillance, and that I think for the school systems, there's not necessarily a specific strategic imperative or requirement. I wanted to potentially give Dara some kudos about, through her strategic partnerships in our community here in Texas. Usually Dara will work with large companies to help consult with how to improve their employee health through our services or just any service in general. And through some of the partnerships she's had, some of the local school districts have reached out, and we've been consulting with them on how would we approach opening a school like we would help a client reopen their business. And I think there's a lot of early successes about mirroring. It doesn't matter if it's a school or if it's a business, that we would treat, the staff and the students, the employees or the clients or the customers, right? And so, early on, some of the businesses we've partnered with have moved forward with what we call an Axiom certified workforce. So it helps apprise the potential customers of those businesses that their employees are actually under active surveillance. It's not described that technically, but that's essentially what it is. And so we've been partnering with some large school systems to help if they do decide to open, what would be the safest way to do it? And we've really employed a lot of the things we've learned in occupational medicine and preventive medicine with critical infrastructure companies, whether it's food production, oil and gas, utilities. And so all the services that are absolutely crucial for continuity of the country's way of life, shifting that to the school. So I don't know if I've missed anything, Dara. I know you're working very close with some of the school systems, but you may be, I know you're moderating this, but it does a disservice to your actual role here.
No, I think you've hit a lot of points. And I actually think a lot of it goes back to what Dr. Matos said. I think what the school districts that we're working with have identified is they definitely need that transparency with their parents, with their teachers, with their constituents, because this is something that is fluid and may change very quickly over time. And so I think that transparency is a big piece of how they're operating and they're going forward. Now, I do think, interestingly, and I've shared with some of the school districts we're working with the article that Dr. Cherry shared with our executive team yesterday about some of the international schools and school districts and how they've approached this. And a lot of them, I think, went into it thinking they were going to do what Dr. Matos said and try to reduce capacity or rotate and do some different things. But it sounds like a lot of them have ended up more back to business as usual in the schools, and so back to kind of full capacity and normal course of business. But I think some key differences highlight what Dr. Matos was saying too, and you, Dr. Cherry, in that some of the cultural differences in these other locations very heavily support wearing masks, and so younger children are conditioned to wearing masks and some of the general hygiene that we're trying to support through this. And so I think the reasons that we're seeing less or zero almost COVID outbreaks in the schools reopening internationally is some of those cultural differences around mask wearing and general hygiene practices that we don't quite yet have in the United States. So to Dr. Matos's point about the hairdressers, and I had seen that news as well, I think the more we get people in the US understanding some of these very simple practices will lead to a reduction in spread that will have, I think, a big support for schools reopening and how we kind of then work with children and parents and teachers on the surveillance, the active surveillance. How do we work with within these parameters? So I think those are all really great points. And thanks, Dr. Cherry, for pointing that out. I think it's a lot of communication and trying to understand how we as an organization can support schools and others as they think about reopening. And I think, to Dr. Matos's point too, the teachers are the critical aspect of this. How do we make sure that teachers understand and we can support them in the critical opening of the schools and making sure we're helping spread the illness as much as possible? Either one of you, any other comments about schools?
No.
I don't think so.
Okay, next question came from Thomas. Thomas said, isn't the morbidly obese part of the vulnerable population? I think he wanted, last week, he was interested in, as we were talking about vulnerable populations, talking about obesity as a critical component of that. Dr. Matos, you want to take that first?
Yeah, so I think obesity also goes along with generally puts you at risk for insulin resistance, diabetes. It also puts you at increased risk for hypertension. And we know that people with hypertension are very much in the bullseye of COVID. They're very much at high risk. The belief is some of the receptors that cause hypertension, if they're not treated, allow the COVID virus to bind better in the airways and things. So obesity is a risk factor, but delving a little deeper, if you are obese with untreated hypertension or untreated diabetes, those would be significant risk factors. So just obesity in and of itself is generally a risk factor, but from the studies I've read, and I'll let Dr. Cherry weigh in too, some of that risk can be mitigated if you have your hypertension treated, you have your diabetes under control. And Also with this, we see in communities with health disparities. There's a report that's going to come out in the Boston area where they looked in different communities. And in those areas where they compared people that say had health insurance in one zip code that were the same age, same weight and everything, put them in another zip code, and the outcomes in those zip codes with poor access to healthcare, poorer access to insurance had worse outcomes. So it really also proves the point of the population health piece, that even if you have a risk factor, that risk factor can be mitigated proactively with health screenings. The simple things will carry you very far in medicine, but especially also now in COVID, diagnosing hypertension, diagnosing diabetes early, and often will protect your worker population. So I'll stop there and let Dr. Cherry weigh in.
And I definitely concur your statements there. And as I'm reading the question, if the question is asking maybe not so much the technical part, but which level of obesity is considered vulnerable, obviously there's different categories of obesity, and morbid obesity, which may be being phased out as a nomenclature for that. Obviously it can be based on your BMI, which is your height and weight. But the CDC is advising that actually the first category of obesity, so if you're using the old nomenclature, it would be actually just obesity, not morbid obesity. So it's the BMI of 30 or greater. And again, BMI is kind of a crude tool. It doesn't take into account a lot of things. So the things that Dr. Matos spoke to are actually much more important. Obesity, diabetes, those are very large risk factors for COVID. But what really is the underlying mechanisms of those diseases share a similar pathology or derangement of sugar metabolism. And so we have a hormone insulin that is released when we eat carbohydrates or sugar to normalize our blood sugar. And so diabetes is basically, a high blood sugar. And you may actually have obese people that actually aren't diagnosed with diabetes, but if you actually looked at their insulin levels before their blood sugar levels, you would see that the insulin levels are actually quite high. So I actually call that pre-diabetes. And so all of these effects have huge impacts on our immune system. And so that's why people with this insulin resistance, whether it's manifest in diabetes or obesity, are at higher risk for infection and severe infection because their immune system is working against the high blood sugar. And so it's not nearly as efficient as it would be if your blood sugars were normal. So even if you are diabetic, if you can really spend the effort now to work with your personal physician to normalize your blood sugars, that should greatly improve your risk profile. And so I think what we're seeing with COVID is that chronic diseases where we feel like, hey, here's a condition I should be dealing with, but I'm going to put it off until the future sometime. COVID has kind of brought these chronic medical conditions to more of an acute phase where it's like, with this pandemic going on, I need to really take my personal factors. We're talking about population health here, right? And so we're talking about, large populations, but what that speaks to is everyone here, including myself, needs to make sure my blood sugar is good and that I'm optimizing my health to survive the pandemic.
Yeah, those are great points. So I think that we will continue to see the addressing of personal issues or personal health concerns in order to reduce some of these population concerns. So thank you both for that. Next question came from Mike. This has been a topic that Dr. Matos and I have definitely been addressing in a lot of our conversations with some joint clients. How do we balance HIPAA protection against the need for contact tracing? Dr. Matos, you want to take that one first?
Right. So HIPAA does not apply in a public health emergency. Think of it from an employer perspective. It's the OSHA general duty clause. You have a duty to protect your employees. And before COVID, let's say you had someone that showed up with multi-drug resistant tuberculosis. I think everybody on the line would be like, oh my gosh, it's multi-drug resistant tuberculosis. Exactly. It's the same thing with COVID. You are allowed to ask COVID specific questions to protect your workforce. What you're not allowed to do is to ask, do you have diabetes? How's your hypertension? You could ask, and you could ask just generally, sending out to your workforce, are you in one of the CDC high risk categories? If so, please contact our human resources for an ADA accommodation. That's something different. But when you're screening your workforce with health questions, that's not HIPAA. That's a public health emergency. And it's really, really important to understand the difference. And there's information on Health and Human Services website, the EEOC, and then also the CDC's website on these different nuances to these things. But obviously you still want to err on the side of less is better. So your questions are just really targeted just to COVID, not to necessarily personal health questions. If, however, you can get into that, right? If somebody says, oh, well, I saw my doctor and they want to disclose that, you almost have to stop them and say, no, I don't want to know. So with some of my clients, they have outsourced it to companies like Axiom, who do a fabulous job with their nurse line to really work through those things. Other companies I've seen insource it, but as the cases have increased, I think it becomes difficult to walk that line because it gets a little bit more complicated.
Agreed. Dr. Cherry?
Yeah, I agree with everything you said. I think the only nuance I would add, just to kind of reinforce being careful of when your employee does disclose to a supervisor or someone in the business is, obviously the employee can disclose protected health information. And I'm not necessarily talking about HIPAA, but just protected health information in general. What I advise our clients is that, the best is not knowing, and then the next best is trying to stop it. But once that information is in your hands, the employee disclosed it to a certain person within the company. What I've seen potentially is that then these business managers, leaders, or directors use that information in an ongoing conversation with other people in the company. And that's where I think there's the biggest risk, because the employee can divulge the information to their supervisor, to a coworker, but it's when it goes beyond that, because there was no actual consent given for any further use of that information. And so it's kind of like a hot potato. You don't want to have it, but if you have it, you don't want to do anything. Well, I guess it's not like a hot potato, because hot potato, you want to pass it along, right? So that's not a good analogy, but you really just want to try to isolate it, maybe insulate it, right? That's the I don't want to force that analogy too much, but again, what happens though is business leaders, sometimes they get used to this. Oh, well, Scott Cherry told me he has this issue, and so he starts discussing it with other safety or HR, and that's where maybe the potential the unconsented, or I'm not sure the word, but it's a non-consented release. And so really you want to try to push off all protected health information to someone who's trained to do it within the company, or to outsource that component of it.
Yeah, thank you for bringing up I'm sorry, go ahead, Dr. Matos.
I was going to say, Dr. Cherry, I think brings up a great point. That's absolutely right. And maybe a better analogy is like a disposable ice pack. You hit the ice pack, you use it once, you take that information, throw it out. That's it. It doesn't go any further than that supervisor. But that is actually a great point. That's where a lot of lawsuits happen, is that it's that secondary disclosure that gets people in trouble.
Yeah, exactly. And I was going to say, thank you for bringing up the consent piece. I think that one of our main tenets of guidance for clients has been, look, there is a need to know to a certain extent to protect the population of your employees. However, this consent component is critical. And if an employee is not giving explicit consent, you just need to be very careful about where that information goes and how it's used. So really great points. So this was a question that came out of some of our topics and conversation last week. Stephanie asked, she said, one of you identified new CDC guidance on testing at 7 days rather than 5. So I think this was the conversation we had around at what point during the disease is testing best utilized rather than 5 days. And I think they just wanted some guidance around where you would locate that. I think, Pete, this was probably something you were going through.
Yeah, so right now, I think the CDC, I think you can you can get out of quarantine based on time or on testing. And right now, testing is very unreliable with how fast you get those results back. So the CDC does recommend, I believe it's day 7. There's a new paper that came out. That's the optimal time. It's 99.9%. Day 5 is probably somewhere around 97% likelihood of picking up active COVID disease. So the one thing, the test you want to utilize to pick up active COVID disease is that nasal swab, the RT-PCR. The CDC did come out this week and they clarified they do not recommend utilizing serology to return people to work or to pick up active disease. And that makes sense because the serology blood test, that's not what they're meant for. It's meant to help me determine if I had a complex case, if the person mounted a proper immune response in the past and perhaps has other medical complications. It's really not meant for return to work. So on the testing piece, the takeaway is earliest you could really test is day 5. Optimally, as the CDC said in the latest evidence-based medicine, day 7 is optimal to test after, say, an exposure, and that's the deep nasal swab RT-PCR. So I'll pause there. And did you want to add anything, Scott?
I think maybe that was an excellent technical report. Maybe what I would just add is, testing, I think in a lot of ways in the general media has been described as kind of the way we're going to get through this. I think it's going to be a piece of the puzzle, but testing by itself will not be helpful. And just based on the nuance of this question and in Dr. Matos' response, you can tell it's a very intricate way. It's not as simple as just getting people a bunch of tests. It depends where they're at in their disease course. It depends if, we've kind of seen everything where people are getting tested when they're exposed. And so just testing a lot of people is not going to provide meaningful data. It will help in some cases. It will actually hurt in what I would say almost the opposite half. And so, testing it's a tool, but it needs to be employed very appropriately and strategically. And so, I think these are just great examples of how testing can actually give you the wrong message, right? So say you test at day 1 of symptoms and you have a negative test, and then you allow that person to go into work. Axiom, me and Dara have worked very very tirelessly in the sense of we've been holding the line since day 1, where if someone is symptomatic but has a negative test, we do not allow that person to return to work, or that's our opinion, to the company. And I think that's provided a lot of value for continuity of operations, just because one, the test itself may, this was early on, may have up to a 10 to 30% chance of a false negative early on. I think the technology's gotten better. The sampling methods just may be different, and that may add to that false negative, but it also matters in the disease spectrum. So, you could have all these things work against you and get a negative test, but this person is truly infected. And so You want to have a mix again of a testing strategy, but of a syndromic surveillance that I think the three of us have spoken about previously.
Yeah, and also on the flip side of what you just described in terms of a false negative, Dr. Matos and I know you have too as well, Dr. Cherry, we've started to see individuals that have been positive in the past continue to remain positive throughout the testing protocol. And so again, a lot of the complexity around testing becomes, what do we do with this extra information? If somebody continues to be positive, even though they're not in an active infectious state, how do you manage that? Because then you've got somebody continuously testing positive, and that's where some additional data points, like with the serology tests and other testing mechanisms, are there. But you have to be very careful with how these tests are used for return to work, for somebody being in the workplace, both on a positive and negative side. So it does bring in some cases, quite a bit of complexity that maybe wasn't there in a syndromic screening process.
Go ahead, Pete, sorry.
I was going to say, I think as you can tell from Dr. Cherry, speaking, testing is very complex. We could probably have a 2-hour session just on testing by itself. I think the moral of the story is you really need to have a health expert guiding you. And just as Dr. Cherry said, I've had a number of clients where exactly what Dr. Cherry described, local clinicians deployed testing too early, which then created an outbreak, a significant outbreak for some of my clients. So it's really important to, I think, have that medical expert on to help you navigate through, the complexities of testing with COVID. But the simple and most pure and honest way to do it is really by time in syndromic surveillance, as Dr. Cherry spoke to.
Yeah, maybe just my last comment, and it goes to what you're saying there, where it's been clear that there's a concern for persistent positive once someone has kind of gone through the course of symptoms. And so if someone's tested positive early on in their disease course, there's a high likelihood that there'll be a persistent positive. There's been studies that have shown that when someone recovers, the PCR test is so sensitive in detecting pieces of the genetic material that it's actually able to detect non-viable virus through this pieces of genetic material. So actually late last week, the CDC is now speaking to, you have, again, a return to work or discontinuation of social isolation. There's two strategies. There's a symptomatic strategy, which is the syndromic surveillance that we've been speaking about. And then they have a testing strategy. But now they're actually speaking to this persistent positive, and they actually advocate for a symptomatic approach, which has been our old school approach from kind of day one. So if someone's tested positive, once they meet that return to work or that criteria of discontinuing social isolation at that 10-day period, that you actually do not use a test, because what that does is that will prolong that isolation period without any real value to the person or to the population.
Yeah, great points. Thank you. That's all of the questions we had from last week. And this actually went a little longer than our normal conversation because I do think we have some great information and discussion points. We've got some information up there. I think this was one of the websites that Dr. Matos recommended for information around COVID and up-to-date studies. So this is the website is the covid19.torchinsight.com. So that has a lot of really great info we can share with everybody. In addition, I wanted to share next week, we have our next webinar topic. It's Pandemic Resurgence, How Can We Recover? It's a webinar led by our CEO, Mark Robinson, and will be a lot about how do we can move forward through this pandemic and how or can we recover at this point. And then we have some other great topics coming up as well. So please join us. If you ever have any questions in the meantime, drop us a line at coronavirus@axiomllc.com, and we'll get those questions answered in our next webinars. We also have our white paper that we've talked about a lot from our Chief Legal Officer, Chuck Cable, and it's a really great resource if you have a lot of questions about risk mitigation, a lot of the topics we talked about, such as personal health information, HIPAA, how do you then approach this pandemic as an employer and the risks associated with it. So thank you all for joining us. We appreciate it, and we'll see you next week.